Thank you very much. Good morning, and thank you for inviting SCD to come and speak to you at this workshop. My name is Richard Oliver. I'm the Head of Technical and Clinical for SCD in the UK. While I think about it, we share our premises in the UK with Medi UK, and we used to part own Medi UK, so we're very, very closely linked with the Medi company ourselves. I'd just like to talk to you a little bit about the product, about how it works, and some of the issues in terms of adverse events and the profile in relation to our product. So I'm going to talk a little bit about sclerosants, how they work, a little bit of comparison between our sclerosant Fibrovane and other sclerosants. Do people use etoxysclerol in Serbia? Yeah, that's available in Serbia, is it? Okay. Some factors about the foam, because whilst it's a very simple process to make sclerosant foam, there are some factors that can affect the success of actually the foam generation itself, and a little bit about the adverse events and how to minimise them. But largely, minimising them comes down to good technique and good compression. So you're in the best place to learn about that today. There are different groups of sclerosants that are available across the world. The biggest group of sclerosants are known as detergents. So that includes sodium tetradecyl sulfate, which is Fibrovane, across most of Europe and many other countries in the world. You may have also heard of Cetrol, which is an Indian product, and Sotradecol, which is an American product. The other main detergent sclerosant across the world is polydocanol, and the biggest company, or the biggest name of that, is etoxysclerol, although it's also known as other names in other countries. In some countries, especially in South America, other sclerosant solutions are used, such as hypertonic solutions or chemical irritants. But by far the biggest group are those of detergents. When you inject sclerosant into a blood vessel, it's irritant, it's going to cause damage to the endothelial cells of the blood vessel, it's going to incite the normal sort of reaction you'd expect after damage to cells, and you get a thrombus occurring. Now, it's a thrombus that's different to a conventional venous thrombus in that it's tightly adherent to the vessel wall. So the risk of that thrombus breaking away and becoming an embolus is very, very small. That thrombus then will undergo the normal regeneration procedures, the healing procedures, and you will get healing and fibrosis. So the vein, you hope, then will be closed down. That is also facilitated by compression, because it pushes the edges of the vein wall together and further aids the process of fibrosis. The detergent molecules are just like the detergents that you will use around your house, around your clinic for cleaning. They have a head that likes water and a tail which dislikes water. And when in water, above a certain concentration, they will arrange themselves in this circular fashion, which is known as a mycel. So the water-loving heads are around the outside, the water-hating tails go towards the centre of that structure. If it was in a solvent, it would be the opposite, because that's against water. So the mycel arranges itself like so. There's a critical concentration above which it does that, and for STS it is about 0.75 in saline or 0.2 in water. The only relevance of that is if you wish to dilute the STS further down from 0.2%, it must be done with saline to ensure that the structure remains in a micellar formation like so, and it's going to be the most active form of the molecule. You'll notice that the mycel actually looks very similar to a cell membrane, which is a bilayered phospholipid structure with lots of transmembrane proteins crossing it. And when you mix the detergent with the cells, it will absorb the fats from the cell membrane and break up the cell membrane and absorb it into the mycel like so. And in so doing will destroy the cell because it's broken the integrity of the cell membrane of the cell. Now, sodium tetradecyl sulfate and polydocanol, as I said, are both detergent sclerosants. They're both available in a range of concentrations, but they are not equal. If you have used polydocanol in the past and you wish to use STS, you must remember that although the manufactured concentrations may be the same, the STS is at least twice as potent as polydocanol, so it gives more effect at the same concentration. So clinically that would translate to 1% STS being equivalent to 2% polydocanol. So if you were used to using 2% polydocanol, you would want to only use 1% STS. Otherwise, the concentration of the sclerosant is going to be too strong and the risk of harm is going to be greater. So that is the most important message of today if you're used to using polydocanol. What we do know is that sclerosants are readily deactivated by blood. And a number of studies over the years have looked at this. First of all, Koorosh Parsi from Australia, Mike Watkins is an STD employee in Hereford in the UK, and Mark Whiteley's group in London in the UK have looked at this over the years. And what we know now is it takes a very small amount of blood, around about 0.3 millilitres of blood, to deactivate 1 millilitre of 3% STS. So as Attilio will talk you through the procedure that he uses, removing as much blood from the vein before you inject the sclerosant is going to maximise the effect of the sclerosant on the cells of the vein wall. We nearly always use STS and polydocanol in the highest strengths for treating the truncal veins as foam using the Tussari technique, after Lorenzo Tussari, who's a very good friend of Attilio's. It is a very simple technique. You mix the liquid with air and agitate it, and it generates foam, as a detergent would in your home. If you're using it in the home and you put it in water and you mix it up, it will make bubbles. What we do know is that the syringes that you use can have a marked effect on how good the foam is and how long the foam remains as foam. We have done some studies in our laboratory comparing different brands of syringes and studying the decay of the foam over time, and we have found that there's one syringe that is a conventional 3-piece syringe that works the best, which is the Terumo syringe. Terumo brand syringes definitely work the best. If you have any syringe, it will be lubricated with silicone to help you use it. Silicone is actually an anti-foaming agent, so it will break down the foam rapidly. So there is a silicone-free brand syringe called Inject, but that's very difficult to use because it's not lubricated and it's very stiff and difficult to use when you're trying to inject into a patient. So this is just showing you what happens at time 0, and this one in the middle is a silicone-free syringe. This is a Terumo, and that's a BD branded syringe on the other side. After 150 seconds, they will all start to reconstitute into liquid. The silicone-free is the best, but following that is the Terumo, and the others were way behind that one. So it's the silicone that's in the syringes that can affect the foam. So if you are making foam with your sclerosant and you find that before you've had a chance to inject it into the patient, there's already liquid forming, it is very likely it's the brand of syringe that you've used that's causing that. So it's the silicone in the syringe, which, as I said, is an anti-foaming agent, but there are lots of ways of applying the silicone to syringes, either as a spray, a dip, a wipe, and then there are different ways of curing that onto the syringe. So it's some factor of the way that Terumo make their syringes that influences the leachability of the silicone from the syringe. The maximum doses that you can use, this is what's quoted on our product characteristics and on the patient information leaflet. For 3%, the maximum dose in 24 hours is 4 millilitres. For all of the other strengths, it's 10 millilitres. So that will enable you to do most treatments comfortably. If you're using it as foam, though, it is dictated by the volume of the foam, of the total volume of gas, rather than the strength of the sclerosant. So it's 16 millilitres of foam, assuming that you've generated the foam using 1 part liquid to 3 or 4 parts of air. Now, adverse events, there are lots of adverse events listed. There is a general consensus as to how you report them, from very common down to very rare. This is the latest listing from our product characteristics from our latest European licenses. You'll see that some of them are quite common: thrombophlebitis, which can be minimised by effective compression. Skin discoloration, pigmentation is a reasonably common complication. It's very difficult to eradicate altogether, but again, good compression to remove as much blood from the vessel will minimise that. Some of the other adverse events are neurological in nature and sometimes possibly related to the gas in the foam. And I'll talk a little bit more about those in a moment. Anaphylaxis and thromboembolic events are very, very low, so you don't need to worry overly much about that, but you still should be vigilant. When using liquid, the adverse event profile is even safer, but liquid will only largely be used for spider veins from telangiectasia. I think, Attilio, are you going to do some spider veins later? Yeah?
I don't know if
No.
spider vein.
We may see some spider veins treated today, but they will be done with liquid, not with foam. So, pigmentation can occur with any sclerosants. If you use an inappropriate strength, you're more likely to get pigmentation. The pigment comes from the hemosiderin, from the breakdown of the red blood cells. It generally will fade within 12 months, but it can take a long time for the pigmentation to fade. So it's important that patients are warned about that. If you can reduce it by using good compression and using an appropriate strength sclerosant. If you use too strong a sclerosant too close to the surface of the skin, you're more likely to get pigmentation. But you also get pigmentation after thermal techniques and after surgery, so it's not unique to sclerotherapy. It's one of the things that surgeons who like doing surgery and thermal techniques will say, oh, well, you get lots of pigmentation with sclerotherapy. You get it with all techniques. It's just a reaction from the blood. Thrombophlebitis is blood trapped in the vein, which can occur following sclerotherapy. It's uncomfortable for the patient, it irritates the patient. Again, compression, good compression, good compliance to compression can reduce that. If it persists, then simple aspiration with a large bore syringe or with a stab incision and removing the coagulum from the vessel will give instant relief. The worst possible complication is intraarterial injection, because if you inject it in an artery, the sclerosant is not discriminatory. It doesn't look at what vessel it's in. It will do the same to the endothelial cells of an artery as it does to a vein. It will kill them. It will cause the vessel to shut down. But with an artery, you're going to then risk the loss of blood supply to all the tissues distal to that point of injection. You will likely then risk an infarction. There's no real protocol been devised to give the best outcome if you do this. The best way to prevent this is good ultrasound investigation beforehand so that you can be sure you're not injecting into an artery. It's a lot more likely the closer you get to the foot, because anatomically the vessels are closer to each other, the arteries and the veins. So it's a preventable complication, but a very nasty complication if it does occur. Just in terms of the neurological adverse events, as a condition of our license in Europe, we are required to undertake a post-authorization safety study. focusing on the neurological events following sclerotherapy. We've got 20 participating centres currently in the UK and France, and I've been talking with Attilio this morning in Italy shortly as well. We're collecting data on the day of the procedure and at any follow-up appointments. And since January 2015, we've accumulated 7,500 patients so far. And the incidence of the neurological events, headaches and migraines, visual disturbances, arm weakness are as listed there. They are very low and broadly in line with our summary product characteristics currently. We have been asked to get 10,000 patients for this, which we will get, but the incidence of adverse neurological events is very low. Exactly what causes those, it's not sure, it's not clear. Some would suggest that it's the gas in the foam causing an air embolus effect in the cerebral circulation. It's much more likely if you've got a patient with a patent foramen ovale in the heart, because the gas will quickly enter into the arterial circulation and straight up into the cerebral circulation. There's a doctor in Italy, Ferrellini, who would suggest that the neurological adverse events are related to endothelin-1, which is released from the damaged endothelial cells. We genuinely don't know, but if you do follow a good technique, don't introduce large boluses of foam at each injection site, or when you're using the catheter, just do it in small amounts, then you're going to minimise the risk of adverse events significantly. Fibravain is available in Serbia since 2014. Ecotrade, Helena is here, who you can speak to if you don't have Fibravain and you wish to get it. And we hope that you will enjoy using Fibravain, enjoy the success that you will get using Fibravain here in Serbia. That's what I wanted to cover. Thank you very much for your attention. I will be here all day if you have any questions you wish to ask me about Fibravain. Okay, thank you.